Hello, and welcome to today's webinar series titled Learning Together, Delivering in Uncertain Times. Please note that this session is being recorded. We're pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French on the interpretation menu at the bottom of your screen. If you need support at any time during this webinar, you can reach out to one of our producers using the chat feature. My name is Lindsay Yarrow, and as the Senior Improvement Lead on this program, I'm excited to be joining you as the co-host for today's webinar. I would like to start by acknowledging that we are meeting on land that has been inhabited by Indigenous people since the beginning. In particular, I acknowledge that I'm hosting the webinar from Kingston, Ontario, which is the traditional and unceded territory of the Haudenosaunee and Anishinaabe peoples. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. At Healthcare Excellence Canada, we continue on our learning journey and commitment to support improvement with and for all people in Canada. Please take a moment to introduce yourself in the chat box. I see some of you have been doing that. That's wonderful. Let us know where you're joining us from today and if anyone else is joining you in the same room as well. I'd like to take a moment to acknowledge that today is National Day of Mourning, a day set aside each year to remember those who lost their lives or have been injured, become ill as a result of workplace incidences. I'd also like to reflect on the many families, caregivers, friends who have been deeply affected by these tragedies, particularly during the pandemic, and especially for those delivering care to people and at greatest risk of COVID-19. I'd like to acknowledge and thank you for continuing to show up to work, delivering the best possible care under these very difficult circumstances. Thank you for all that you do to care for some of the most vulnerable and underserved members of our community during the pandemic and as we move forward. Healthcare Excellence Canada represents the newly amalgamated organizations of the Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement. We work together with patients and partners with a goal to deliver lasting improvement in patient safety and experience, work life of health providers, value for money, and health of everyone in Canada. We are an independent, not-for-profit charity funded by Health Canada. We are pleased to share that this program is delivered in partnership with the Canadian Centre on Substance Use and Addiction and the British Columbia Patient Safety and Quality Council. Today, I'm excited to be joined by my co-host, Ryan McCarthy. So Ryan, before we get too far in today's webinar, I'm going to hand it over to you to introduce yourself.
Great, thank you, Lindsay. I'm Ryan McCarthy. I'm the Director of Knowledge Mobilization with the Canadian Centre on Substance Use and Addiction, and we're pleased to be co-hosting this webinar and working on this program with our colleagues at Healthcare Excellence Canada.
Great, thanks, Ryan. I also want to introduce our speakers for today's event, Dr. Jeanette Wagemaker-Schiff from the University of Calgary and Alana Jones from Fred Victor. If you both want to turn on your cameras now, I'll hand the virtual mic over to you so that you can introduce yourselves as well. Jeanette, first over to you.
Thank you so much, Lindsay. I'm a professor at the Faculty of Social Work at the University of Calgary. And what brings me to this table is the research that I've been doing over the last 6 years that's been looking at the psychosocial stressors and supports for staff who are working in the homeless sector. And more specifically, a research project that I began last year with Alana Jones as one of the key knowledge disseminators in looking at the impact that the pandemic has had on the psychosocial needs of staff in the homeless sector. I'll turn it over to Alana. Go for it.
Thanks, Jeanette. My name is Alana Jones, Director of Housing Access and Support Services here at Fred Victor in Toronto. What brings me here today is to co-present the work that Jeanette and I have been doing, and specifically really interested in the impact of trauma on frontline staff.
Thank you both, and we're really looking forward to hearing from you shortly, so we won't make this next section too long because we're eager to get back to you. We do want to share a bit of where the program is going first before we hand over to Alana and Jeanette. So ultimately, this program is about improving, sharing, and learning. We're bringing together teams from across Canada, working in shelters, serving those who are experiencing homelessness, and residential substance use facilities to improve pandemic response and recovery. Our applications for seed funding that supported internal improvement opportunities have closed, but our virtual learning series is really just getting going, and it's growing to meet your needs. You'll see the 6 general areas that we'll be focusing on. We call these promising practices, but really kind of a much deeper dive than that. So Ryan, I'll hand it over to you to talk a bit of what that looks like.
Great, thanks, Lindsay. So we've put together a virtual learning series that will provide 3 types of optional learning events that you can attend. Webinars, which will be a 1-hour session provided every 4 weeks and provide an overview of various topics. Speakers will be invited to share their expertise on a selected topic, followed by a Q&A session. Huddles, which will be 30 minutes in length and provided every 4 weeks, generally 2 weeks after the webinar. The huddles are an opportunity to get a bit more focused on the same topic as the webinar that preceded it, and provide an opportunity to delve deeper into the topic that was discussed. Speakers will be invited to provide a short overview of a consideration within the topic, and participants will engage in a discussion. Workshops. Workshops will be provided every 2 to 3 months, and speakers will provide education, tools, and resources on a specific topic, as well as guided activities to allow participants to apply the knowledge, tools, and resources in a bit of a deeper dive. The duration of the workshops will depend on the topic. We ask people to share their learning objectives to not only determine how to best support them, but also to have a better sense of some of the challenges on the ground. This is a direct result of hearing from a number of groups that they are facing challenges in addressing the psychological health of their staff, whether it's preventing burnout, helping to balance the demands of continually shifting work and home priorities in an uncertain pandemic, to having the right personal protective equipment to make them feel as safe as possible. Needing general psychological support as individuals experiencing the pandemic is very important. Before we get started, I just wanted to highlight, if you have any questions or comments, please feel free to share them in the chat box. For those who would feel more comfortable reaching out to a member of our team regarding your comment or question, please feel free to reach out directly to Tanya McDonald in either official language. I am now pleased to hand the webinar to Jeanette and Alana. This topic is incredibly important, and we look forward to not only the presentation, but the subsequent dialogue, including the question and answers that we have made time for after the presentation. And now over to you.
Thank you so much, Ryan. Welcome, everyone. I gather this is the inaugural presentation, so I hope I do not disappoint. Could we have the next slide, please? Because we're really looking at a research program that began 6 years ago to look at what are the psychological needs and stressors of staff who are working frontline in the homeless sector. And that has now evolved into a deeper dive looking at what are those needs and stressors in the time of COVID, and being able to compare what happened in the previous 5 years with what's been going on in the last year. So why was I originally drawn to this? Because there was a lack of recognition of work-related mental health stressors within the sector. And there was, my concern was whether or not traumatic stress was really greater than burnout. And I will get to that because this is a really important finding that has been consistent throughout 6 years of research. There were concerns about the adequacy of staff training, supports, and salaries and benefits, and some suggestion that those were related to high rates of turnover, which is very costly to organizations. And I will get to that and address the fact that indeed it's not all of training, supports, and salaries are necessarily related to high turnover, which is also interesting. And then in terms of the experience with COVID and the precautions that staff needed to take, was this creating additional stress and burden, and to what extent may this be impacting? We're beginning to get preliminary answers to that, so I'm not quite as definitive on those conclusions, but we'll move forward. Next slide, please. I hope I'm not talking too quickly. If someone just interrupt and tell me if I'm going too quickly. So a very brief overview of this. I started this research in 2014 when I was asked by actually the Calgary Homeless Foundation, which is an umbrella organization that coordinates and supports the homelessness service sector in the diverse programs that are available in Calgary. They were interested in reports about burnout. So I will tell you right now, we're going to talk about burnout, but I'm going to say it's not burnout, it's stressed out. And those are two very conceptually, they're related, but they're different. And that's important. Over the course of the last 6 years, we looked at emergency shelters in Calgary and then the shelters in Edmonton. Then we looked at all of the domestic violence shelters in Calgary. And we also looked at the homeless housing and support services in St. John, New Brunswick. And finally came back to look at housing and support programs serving homeless people, but not the frontline shelters in Calgary. And those results have been actually relatively consistent until we come to the new study, which is funded by the Canadian Institutes of Health Research and is looking at 7 cities across Canada. So we're looking at Calgary, Edmonton, and St. John because we have prior data. So we'll see whether staff are faring better or worse than they did before COVID. We've added Toronto, Thunder Bay, Fredericton, and Moncton. So we're pretty well spread throughout Canada. We don't cover all of the major cities, but it's a good beginning. Next slide. So in our prior work, we found when we asked people if they had reported any kind of major distressful or traumatic event in their lives, 95% report at least one major life stressor that, according to research, is predictive of PTSD. So these are called PTSD precipitants. And 55% indicated that one or more traumatic events happened at work. So what we documented was that working in homeless services put staff at a significantly high rate of risk for experiencing traumatic events as part of their job. This was really important because it's the first time that we were, apart from police, firefighters, and EMTs, that we know are involved with traumatic events, and emergency room staff who repeatedly encounter them. This was the first report that really suggested that the encountering of traumatic events in the workplace outside of a medical or emergency services sector was really high, and it's actually alarmingly higher than other areas. Next slide, please. Okay, so the results of our study show that between 33 and 41% of staff reported rates of traumatic stress that would qualify for a PTSD diagnosis. So we used a quick screening instrument to screen for those prominent symptoms that 95% of the time would be confirmed diagnosis of PTSD. And the reason for the range from 33 to 41% is that in our original study in the shelters, we were looking at 33%. And then 5 years later, when we were looking at all of the programs in Calgary, the rate had gone up to 41%. And I'm not sure whether that rate has increased because the stress has increased, whether we're looking at a somewhat similar but little bit of a different group of workers, or a combination of the two. But the interesting thing is that you look and see 24% of staff report burnout. And this finding has been really consistent across all of our studies. So all of our studies show that staff are more stressed out than they are burned out. And you may ask, well, what's the difference? And should it make a difference? Can we go to the next slide? Because I forget whether I go into the differences or not. Yeah, here a little bit. So, I like to use graphics sometimes in terms of what's the difference between stressed out and burnout. With burnout, it's like the fires are dying. You no longer have the interest or the energy to care. You may be feeling a loss of idealism, of realism, a diminished feeling of accomplishment. You're frustrated, angry, and depressed. You may be cynical. Whereas with traumatic stress, You may have anxiety, you may have fear, you may feel exhausted, but it's an emotional exhaustion. However, you also have intrusive reminders of traumatic events. Um, you may have a number of other stress symptoms, um, and you may have an alteration in your personal life view in terms of trust and safety, control, intimacy. But the important thing is that you don't lose the ability to care. So people who are stressed out still care. They still get derived satisfaction out of helping with people, but they're feeling extremely emotionally depleted in terms of being able to reach out. Whereas people who are burned out just really don't care anymore. I could use stronger language, but I think that gets the message across. Could we have the next slide, please? Thank you. Okay, so here is actually the slide where I have gone over these symptoms and what's the difference between the burnout and the traumatic stress. Next slide, please. Okay, so in our current study, what we've done is, as I said, gone to 7 cities, invited key organizations to participate. Almost all work that's been done on secondary traumatic stress, vicarious traumatization, etc., has looked at convenient samples and kind of sending a survey to a whole bunch of people and saying, could you please participate? And the participation rates have ranged from a low of 3% on national surveys upwards to 30, 40, 45% in more targeted surveys, but they never get more than 50% of people who are eligible to participate. And the big question always with that is, well, are the people who are actually filling out these surveys, do they still have the energy left to do it? And the people who are so depleted just don't have the energy. So what we've done with our study is we've keyed in on key organizations and said, we'd like you to participate, but what we need for you to give us time to meet with all of your staff to explain the survey, that you will provide at least a half an hour of staff time for staff to go away during the workday to either complete the survey or not complete it. That's their choice. And then and we will take that information and go from there. So our participation rates really were extremely high, and they have ranged in the previous studies from between 85 to 100% of all eligible participants. So we're pretty sure that we're capturing virtually everyone. Next slide, please. Okay. The levels of traumatic stress during the COVID pandemic. Those who work primarily from home, 56% report levels of traumatic stress that might qualify for a PTSD diagnosis. Those who work directly with clients in shelters, soup kitchens, etc., report 52%. Actually, when you do the data analysis, those two figures are not statistically different. There may be 4% difference, but it's not enough to say they're really different. But it's interesting that those who work remotely were not reporting a much lower rate than those working directly. Both of those levels are statistically more significant than the previous reports. I told you the data on the previous report. So we've gone from 44% to 56%, which is a huge jump. And so the other part of this is, and it's not in the slide because I did the analysis, this data has just come in the last couple of weeks, so you're the first to hear about it. And that is that we continue to see 24% of people reporting burnout. So you got 24% of staff reporting burnout or high levels of burnout, as what the literature suggests it is, and 56% reporting high levels of traumatic stress. Next. Okay, so potentially, what are the greatest stressors? Now, I may say that some of this is not yet coming out of our current data analysis. We haven't gotten that far, but we will within the next couple of months, hopefully have much more detailed understanding of what this is all about. Are the stressors the lack of physical or psychological safety? Do they have much to do with PPE and fear of contagion? does it have to do with the inability to work from home? Well, actually, the inability to work from home doesn't seem to be having an impact, at least not in this preliminary analysis. Inadequate time off to recover from stress when there has been a precipitating event. Again, we don't know. When people have critical roles in assuring the safety of extremely vulnerable people, does this add to it? Is it the availability of supervisory supports? Is it the fear of a loss of income due to illness? These are questions that we're analyzing as I speak, and I hope we'll have some other answers to that. I will say, though, that it seems to me, in thinking about all of this, that the rise in traumatic stress may not all be due to whether or not people are working directly in situations where there is a high fear of contagion, because our workers working more from home are reporting just as high, if not higher, stress levels than workers who are reporting working face to face. Next slide, please. Okay, so we've got a lot of threats and opportunities in terms of looking at these issues. The threat is that there's a lack of recognition of the vital role that frontline workers play in supporting and taking care of an extremely vulnerable population. Vulnerable in many different ways, and certainly at much higher risk of contracting COVID and suffering serious consequences. We also know there's a threat because there is a pervasive lack of adequate education and training and supervisory support for this staff. And this continues to be the case even through our latest round of data collection. And there's certainly a lack of training in trauma-informed care, not only as it applies to clients, but also as it applies to individuals. Our opportunities with this, and we've begun to work on that. Alana and I have had actually meetings with several key people in political office who our message to them is, we want to see legislation that really enshrines or incorporates frontline workers as vulnerable and in need of a whole lot more support and training than they currently get. We figure the money will flow if we get the policies in place at a provincial level. We need to have increased training and relevant education for staff, and to provide multiple and diverse supports, because not one particular support will not be universally applicable or effective for everyone. And we have to implement trauma-informed care at all levels of the organization. Next slide. I'm turning it over to Alana.
Thank you so much, Jeanette. So I'm just going to talk a little bit about some of the work that we had been doing at an organization here at Fred Victor pre-pandemic and post, not necessarily post, but some of the things that we've done since we're in the pandemic. Some of you may be familiar with Fred Victor. We've been around for 127 years providing support within the downtown core of Toronto, and we have about 500 staff and 22 locations. Next slide, please. So some of the things, like most organizations, things that we were doing is having, an employee assisted program. And we also, a couple years ago, one of the managers had started a partnership with the Ontario Psychotherapy Counseling Group. And they have been really supportive, not just in providing support for clients, but also staff one-on-one. And that really speaks to what Jeanette talked about, having diverse opportunities for staffing teams as well as our clients, to really complement the work that EAP, and oftentimes we're not getting the support that we want from EAP. So this program was really able to fill some of those gaps. We made an effort to do some increased harm reduction supports for staff. So again, in the same way that we're client-centered, really becoming more staff-centered, ensuring that staff who needed to have harm reduction access, that it was there and that information was there to support staff without judgment. Again, one of the things that I know most of us struggle with at times is that you're unionized, you're thinking, can we do this, can we do that? But we really embrace the fact that the union was a part of the organization, and it was a partner. And so how do we ensure that we work together with the union to ensure that staff were being supported? Ongoing staff recognition. At the end of every year, we recognize staff service within the organization, always really important. And then ongoing coaching for both staff and managers. Next slide, please. When the pandemic hit, we started really having to think about what are some of the supports we needed to support the staff, because while they're protecting the clients, they also had to think about protecting their own families. We all know the first 3 months was quite difficult for a number of our client-facing teams, our housing locations, shelters, as well as our community mental health teams that were going out into the community. And as a senior leadership team, the organization started ensuring that we were not just encouraging people to access our EAP program, but we ensured that everyone across the organization had access, regardless of if you were contract, a project staff, relief within the organization. The other thing we did was to recognize that it was an incredibly stressful time, and really happy that we were one of the first organizations to decide that we're going to have a pandemic pay. And this was long before we heard anything from provincial or city or federal government in regards to compensating staff because of the increased pressure. We expanded the partnerships that we had to ensure that, again, all staff, had the opportunity to get that support. We also brought in a psychotherapist that started working with managers, helping them from that trauma-informed place, not just in supervision, but also in team meetings. So they had someone who was quite familiar with working in chaotic environments that can provide immediate support to them so that they could call, I need someone to debrief with outside of my manager, and that person is available to provide support. Next slide, please. We also made an effort to demonstrate that we weren't just being a lip service as an organization, but to really recognize staff in a very tangible way, in addition to the bonus pay. So we had meals for staff, we had really good meals. And then we also had board members also get involved in saying, thank you. We also sent out newsletters that profile some of our staffing teams as well. One of the biggest things that we did as well for about, I think it was probably about a 6 weeks, we advertise our staff on billboard at Eaton Center off of the 401 because, as you know, the profile of the frontline worker was often people in medical facilities or PSWs, doctors, nurses. We weren't hearing a lot about the folks who were in shelters, client-facing, housing folks, community mental health folks. So that was one of the big things we did. And in working with Jeanette, and as we developed the research, we started as an organization, as staff gave us feedback, we huddled very quickly. Again, we increased our meetings with the union. So we were meeting with the union on a weekly basis, updating them. This is what's happening with our PPE distribution. This is what supports we're having for staff. Any feedback that you're getting, how can we, because the union really had worked with us at this point, and not just about surfacing issues, but we had the opportunity to say, these are the policies that we're putting in place to protect staff. They had a look at it before it was sent out. Again, very collaborative approach, and that really ensured that staff felt supported. Next slide, please. So thank you so much. So that's a little bit about what Fred Victor did pre getting involved in the research and some of the things that we did after. Thank you.
Thanks, Jeanette and Alana. And I've seen some comments come through the chat box. So I think folks are ready to dive into some questions and answers. And I think a great conversation to have, very timely. So the first question that I saw come through, Jeanette, I think was for you. And that was specifically from Deborah, who shared that they're an inpatient outpatient addiction treatment center. And the clinical profile of service recipients has changed dramatically. Acuity and complexity are off the charts, and distress levels at admission are much, much higher. So Deborah's question was, I wonder if any attention is being paid to the clinical profile of the clients being served prior to the pandemic and now during the pandemic. And Jeanette, I'll start with you, and then Alana, if you'd have anything to add, we'll move over to you next.
Thanks, Lindsay. You know, I agree, and I understand that the clinical profiles have become more complex, and ideally, it would be nice to have data that supports that and compare that with the impact it's having on staff. So one of the limitations of my research is that it's only looking at staff, and it's not able to factor in the complexity of clients. The closest we get to that is looking at the kinds of impactful events that staff may be exposed to in the course of their work. And I haven't had a chance to look and see whether the current data, the current wave, whether these impactful events have escalated, because we know baseline that we're coming in at 55%. And so we'll have to see. Now, interestingly, I can't find any other studies that have really used this life events in terms of comparing it with the kind of impact that it's having on staff. So it's a great question, but unfortunately, I don't have a great answer. I'm sorry. Alana?
Like you, Jeanette, I certainly don't know what the research on that is, but from a on the ground perspective, we've definitely seen an increase in folks who are not just vulnerable, but the complexities and their needs have certainly become greater. You have individuals who were quite resistant to service in the past, started reaching out for support, you know, so that we're seeing on the ground. But in terms of hard data, I certainly don't have that.
Lindsay, we're going to turn it back over to you. Oh, Ryan?
One of the questions that came up for me is, there's an interesting nuance that frontline workers and workers who are just working remotely from home are both experiencing high levels of stress. Is there any indication for the remote workers? My assumption would have been the frontline workers would have been experiencing more stress, but it looks like it's pretty much on par with each other. Is anything kind of explaining that nuance as to why remote workers are feeling that way?
You know, Ryan, I like the question. It reminds me of the conundrum I faced back in 2015, 2016, when I was first looking at the results from what I considered the burnout study, and kept saying, but they're not burned out, they're stressed out. How do I make sense of this? So it took a little while to kind of figure that out. And I'm kind of faced with that same, I thought it was one thing and it's going to be another. I'm wondering, okay, so this is purely a wonder, but I'm wondering if the reflection that we're seeing is a reflection of a greater level of stress that's being experienced by all of us. And so we're not just measuring the stress that frontline workers may be experiencing, because those who are working at home are getting it too. So I'm wondering whether we're really now looking at the impact of a feeling of being traumatized that is pervasive through society. Now that is a big leap. But given the fact that people working primarily from home are having the same experiences as people who are working face to face, Actually, what I would do is I would ask anyone who is on this webinar, do you have some other suggestions or ideas of how to understand this? It's not all going to come from me. It's going to come from other people who need to add their wisdom to it as well.
I think the interesting thing here, Jeanette, to jump in, that it's while we have folks that are working remotely from home, all of our staffing teams who are doing that still have to do community contact. So they're still going out into the community as well. So it's not just virtual care, and that we might be seeing a combination of, I'm not in a office space, but I still have to go out and provide support. So that might be, but it's hard to tell.
It's true. Well, one of the markers of feeling traumatized is feeling a lack of control.
Hmm.
Okay, so that you're in an overwhelming situation that you can't control, and that you have very little impact on. How do you deal with that when you're so emotionally overwhelmed? My original thinking was that people who are working from home and can schedule their appointments and when they see clients and under what circumstances have a greater control over their work environment. Okay, and yet they're just as traumatized.
I see Anne has her hand up.
Yeah, thanks, Anne. Sorry, within the webinar, we only have the chat function available. So Anne, I saw you started to write in the chat box. If you can potentially continue to give us some more information, we'd love to hear more from you. We're just limited in our tech today. So no need to apologize. We actually haven't talked about that yet in the webinar series. So we will hopefully hear more from you in the chat box. And you were saying in terms of your own workload that it's I think you said quadrupled. It's quite significant working from home. So those pressures on your time aren't changing, and it's overwhelming.
I think the other thing, and I may add to that, is that for many people working from home, especially if they have partners who are also working from home, if they have children who are at school who are now home, and they didn't make any of those choices. It was like you were told to stay home and work from home. So if you're going to work, you're going to do it under very difficult, very demanding circumstances. For those people who live in larger cities where you may be living in an apartment and have much less space in which to operate, and far fewer opportunities to kind of get out and get into some open spaces. This is, I think, all adding to that feeling of being overwhelmed by the pandemic trauma. People started talking about, is the pandemic really a trauma? And I think it really has a lot of elements of trauma that maybe this is part of what we're seeing coming out of this research is that we know frontline workers are traumatized, and part of the traumatization is coming from who they're working with. That we know from before the pandemic. This additional rise is it due to working frontline during the pandemic, or is it due to the fact that we're in this overwhelming situation that is pandemic, that we have no clear-cut ways of controlling or dealing with other than to wear masks and isolate and get a shot and pray?
You
Ilana?
touched,
Yeah,
sorry,
go ahead,
Ilana, go
Lindsay.
ahead. No, I was just going to add to that we know, from our work, how important that peer support model is, and finding others with shared experience and connecting with others really is so important in our work. Ilana, do you have any experience of how that's working at Fred Victor, really finding those peer support opportunities within the team and how that has been received and the outcome of that?
Yeah, I think what we're seeing is we have a bit of a rotation going on. So there's days that folks are coming in who are working remotely to stock up on PPE supplies. But they're more and more they're asking who are their colleagues are going to be in on that particular day, because the brainstorming for around client issues seems to work best in person than over Zoom. So that was also some of the feedback we had. We've also tried doing some kind of fun Zoom things online, but it's not, I mean, it's certainly not the same. But so we're definitely thinking that social isolation is impacting a lot of our staff teams. But someone also mentioned, like, there are some staff who are struggling with some of the virtual resources that's needed to be used during this time, and that also creates them not having the right supports at times. Sometimes just getting into some of our psych consults, for example, people having a lot of struggle to get online, so they miss some of the sessions, just things like that. But it's ongoing, right? So we've tried to work with our IT team as well, to work one-on-one with some of those staff, but it's kind of doing it as it happens. Often we find, and managers are spending more and more time guiding staff through some of those tech supports, even though we're a year in, because there's also some shame around that staff might be feeling. So I think there's a number of pressures, not just um, going out into the community, but also having to manage some of that. You hear a lot of staff talking about just feeling fatigue, Zoom fatigue, not getting out enough. Um, so it is an interesting dichotomy, I guess.
And Alana, kind of building on that point, we did have a comment, a couple of comments actually around the loss of control that people are feeling. So one is around having to connect with staff who might have lower technology skills, but still need that supervisory support. But also the lack of control just to contribute around things like the changing regulations, the length of the pandemic, the whole lack of clarity as to when things may go back to whatever a new sense of normal is. So I guess the question is, how do you kind of manage through that lack of control with staff and kind of keep them motivated and keep them focused during what is really an uncertain time?
Well, for us, as I said, we've had to make some big shifts. So bringing a psychotherapist to work with our teams was really was heaven because they were able to debrief with someone who was familiar with the sector. She provided support in their supervisions, and they had control. So whenever they're setting up the meetings with their teams, managers step out from that, and staff connect with the different psychotherapists and say, this is what we want to be able to meet with you. The other thing is supervisions. Instead of having supervisions over Zoom, we try to have those one-on-one in the boardroom, for example. That was another way we, for folks who were working remotely, to bring some kind of structure so that, we're working with the best we can. But those were ways in which we could still have some kind of in-person. It's not necessarily easy, but I think with a little bit of effort as a manager, you certainly can bring a little bit of control. Um, and also recognizing and asking staff, are you having a hard time working completely from home and working with that? So, okay, you'll have 2 days in the week or 3 days in the weeks, because we also have to pay attention to capacity in the location that we're working from. So that was also another way to create some support for individuals. Some staff talked about, I'm having breaks when my kids are doing this particular thing because I need to support them. So again, really rejigging their schedule. All of those supports are tangible things in which we can support staff.
The other thing we're seeing in the chat box is for those staff who have no choice but to work those frontline roles, right? And the worries that the managers have in those situations as well, right? The vulnerability of the staff who may not have the opportunity to do their work from home and may have additional risk factors that make them vulnerable.
Lindsay, that totally makes sense. And again, we're talking about a data set that is not yet complete. We are still in the process of gathering data. I speak from the point of view of looking at over 350 survey responses that we have online, and a couple of dozen interviews that we have done with key administrators. So we've got a strong data set, but it's not yet a complete data set. I'd like to add one other thing in, that we're currently analyzing and that Alana is taking a lead on. And that is our concern about what kind of impacts the COVID stress, COVID, et cetera, is having on those staff who have lived experience. We know that within the homeless sector that there has been a strong push to have people with lived experience as part of the staff. They bring a value added in terms of their understanding of what it is like to have been through an episode of homelessness. However, what we don't know clearly yet is COVID, or is this kind of work having any different implications for them than it is for people who do not have lived experience? Are we putting people who've been hurt back in a hurtful situation? We don't have the answers. We have some ideas. That's Alana's fire. She can talk more about it.
Thanks, Jeanette, for putting me on the hot seat.
You're welcome.
Of course, as Jeanette said, the data is not in, but from what I see on the ground is that there is something for us to definitely pay attention to there. So stay tuned for that information. But again, going back to that, we also saw that some staff may not have been talking about their journey in their mental health or their journey in regards to their use of substances. And so something as simple as ensuring that we were putting up SHAP's disposal so staff could access and be able to use safely. It's not we're promoting, it wasn't about that, but really recognizing that it's happening and making a clear statement that there is a place and a safe place to ensure that that can happen.
Great. And Coletta shared an interesting point in the chat, and she says, I see another challenge even if working from home. Employers' COVID protocols, school protocols, and public health protocols are not all the same. And one is left at home having to decide which protocols are quote unquote right and what should be their safe space or sanctuary. Any thoughts on how to navigate those conflicting areas and how they affect stress?
I think it's working with people one-on-one. That's what we have done, right? We've shifted people's schedules when possible. Of course, for our folks who are working face-to-face, we can't do that. But for folks who are working remotely, we've certainly, when we can, been able to work with staff around shifting schedules, but it's not easy.
And the other thing that's not easy, and you know, it's a really valid comment. When you have different directives coming from different sources, and you're not left with any clear indication of how it should be prioritized. Whose directives take precedence? It becomes, again, an added piece of stress. And at this time of COVID, I would suspect that many people are opting for the safety first principle. In other words, going with the highest level of restriction. Now, there are some rebels in us, and I say in us because I've been known to be a little bit of a rebel in the past from time to time, who would just like to just throw everything out and say, forget it. But the reality is that we can't do that right now. Balancing those shifting protocols is, I don't think there's an easy answer. I think it's an individual answer, unfortunately, right now. Anyway, nobody's telling us who should take precedence. Anybody else have a comment or a thought on that? Ryan, Lindsay, please join in.
Thanks, Jeanette. Nothing to add, but our chat box has been pretty active, so I'm going to keep moving through it in our last few minutes of the webinar, if that's okay. I saw a comment validating the impact of working from home and being socially isolated, and maybe the impact that has on staff boundaries as well, right? Of trying to find that right place. I think Ron talked about connecting peer understandably seeking out peer connections and support to deal with that isolation, but sometimes that results in boundary crossing. The other comment that I wanted to raise is Deborah had made a note about the impact of racism in the pandemic response, and has added in a comment here. We also need to factor in the impact of anti-Black racism on our collective consciousness of employees and social and of service recipients. It's not just the pandemic that's traumatizing. So that impact of racism. Any comments on that?
It's interesting that this question is coming to a team of a very visibly white woman and a very visibly Black woman. And Alana and I have had frequent discussions about this because it has raised our sensitivities. From my point of view, I would say that, once you're in a traumatizing situation, you become hypervigilant. And maybe in this case, the hypervigilance is really good because it's helping us to become more sensitized and sensitive to issues that have always been there, but we haven't paid enough attention to. Lana, you want to add to that?
I am going to echo that, Jeanette. I think it really highlighted a number of things that have been dormant in the sector and as a society, and it's there. It's getting the attention, and I really think that it's a fine dance. It's a fine dance because at times you're seeing what do we focus on, right? But I think when you think about folks with lived experience, you're thinking about how we deliver service, how we receive service. If we're always going from a place of being client-centered, but also staff-centered, I think we'll make some good progress in this area. But it's not easy, right? But it's two difficult things happening interchangeably.
Thank you. And maybe I'll hand the last question over to Ryan.
Thanks, Lindsay. Another point that came out, which was also interesting, is that there are people that are enjoying being able to work from home because it allows them a bit more flexibility around self-care and being able to manage their time. But the flip side of that is, from a management or leadership perspective, it's been a big adjustment because the accountability that you usually have in a traditional office structure has completely flipped in this virtual world. And the comment that was made is it highlights the importance of being trauma informed, which is not just a statement to be made, but it's also an organizational culture. Any thoughts on that?
Specifically here at Fred Victor, this is where, of course, we're really working towards having a common understanding across the organization about trauma-informed care. So that's one of the things that we've embarked on, not just in specific areas, but more and more the virtual tools that we are using. There is the opportunity to have checks and balances, and I have to trust that my staff continue to do incredible work. And when I say I mean as an organization. The opportunity is there for us to find that balance, but it's an ongoing conversation that we need to have with staff. There's expectations from funders, absolutely, and those things are quite doable, right? But again, I think we all said that case managers couldn't work remotely. The work must happen at home, right? I think we all said that 2 years ago. Our funders said that 2 years ago. But in many instances, the services that we provide, demand for services has actually increased during the pandemic, and service provision has actually increased. But you got to ensure that people are taking care of themselves as well.
I think the other thing with the whole issue of trauma-informed care is it really intersects with issues of power and control. And somehow supervisors feel a greater sense of power and control if they actually see people walking through the front door to do their job and leaving at the end of the day and not taking too long a lunch hour. Well, you know what? People, when you give more of the control and the power to individuals, you give them a sense of self-efficacy. You put them in charge, you're probably going to get equal, if not better, results. But it's a real head shift, as Alana's saying, at the front lines. The changes in people's attitudes and perceptions within the last year have been, in some cases, rather profound.
A special thank you to both of you. I think a really thoughtful and thought-provoking conversation that we hope continues, and we do hope you'll keep us updated on your research findings as we move forward, because I think there is lots to be learned of what's working and what the opportunities are as we move forward. For all our participants, thank you. For all our participants, we're going to pull up our polls on the screen. The first question asks about if you know more about traumatic stress and supporting staff well-being than you did prior to attending the webinar. And that's on a scale of strongly agree to strongly disagree. The next polling question is that you were satisfied with your webinar experience, again, on a scale of strongly agree to strongly disagree. And then poll number 3 is that you'll be able to apply what you learned in this webinar in your work. Again, that same strongly agree to disagree. Any and all information that you share with us is helpful in us continuing to shape this webinar series. If you heard anything today you want to hear more about, please reach out to us. We're happy to find ways to meet those learning needs. Once you're done with your polling questions, just click submit. And we thank everyone again for taking the time for today's webinar. We'll see you June 1st is our next webinar date, and more information will be in your calendars. Goodbye for now. Thanks, everyone.